ureters and the wiener. So I would tell you that I am a surgeon, you know, but I ordinarily dress up for lectures. I feel a little bit bad, but I got caught out in the rain. I was totally soaked, so I was changing to this. It was in my car. So I will tend to use colloquialisms during the lecture, and that means, you know, when I'm talking to patients, no fake. When I mean urethra, I don't say urethra. They don't even know what that means. I say pee hole. Okay. When I'm talking about the scrotum, I don't generally say scrotum all the time. Sometimes I'll say ball sack. Okay. And they know what that means, because half the time they're not going to tell you. People don't want to look stupid. If you say scrotum and they're like, oh, okay, they're not going to tell you I don't know what that means. So a lot of times I just, you know, I just kind of say what comes out of my mouth, and that's not really going to be any different here. So this is the second time I've given this lecture. Obviously, this is your guys for the second class here. So we're going to talk about a couple of different things. First off, some things that happen in kids that you may or may not run into, congenital abnormalities, and then abnormalities of children, and then problems that happen with the testicles that are benign. We're not talking about cancer at all today. We're talking about infections in the urinary tract, and then quite a bit about erectile dysfunction, which is a pretty significant topic nowadays. You even hear about it on the radio. Who knew that would happen in 2018? But we're going to talk about that. So starting out with the urinary tract, this is the development of the male genitals, the testicles. This also would describe the female genitals if there were a C here, because it starts as one in different. Where's my pointer? Okay, can you guys see it when I use the pointer there? Okay. So it starts out as two tracts here. Have you had embryology at all? Done some of that? Yeah. So you got the mesonephric duct and the paramesonephric duct. And those are commonly referred to as the Wolffian and the Mullerian duct. And the Wolffian system becomes basically the male tubes and structures. In the female, the Wolffian duct goes away, or in the male, the Mullerian duct goes away. Sorry, I misspoke. Except for these two elements, which become a little prostatic utricle on the back of the prostate, and then this little thing called the appendix testis. Okay, so what's the significance of that? Well, the prostatic utricle can become enlarged in men, and it can show up on imaging. The same with the appendix testis, can become torsed, and you can have torsion of the appendix testis, and surprise, that's actually a remnant of their female past, or their undifferentiated past. So that's really all you need to know about that. Wolffian male, Mullerian female, the Wolffian ducts form the vas deferens and seminal vesicles. The ureter is the tube from the kidney down to the bladder. It forms as these little buds off of the mesonephric duct, off of what will eventually become the vas deferens, and it merges down with the posterior wall of the urinary bladder. And while the mesonephric duct goes down as the testicles and the ovaries descend, the ureter goes up as the kidneys ascend, and so they tend to cross each other anatomically. Not a whole lot of significance to that, except you got to know that those structures, the ureter and the mesonephric duct, which becomes the vas deferens, tend to be intimate and cross one another. So as I just said, the kidney develops down the pelvis and it ascends into the abdomen, where the testicle actually forms superior to the kidney and descends down into the pelvis and eventually the scrotum. And so that's why the blood supply to the gonads actually originates up in the abdomen, and you've got these long gonadal vessels going all the way down to the pelvis, and in the case of the male, all the way down into the scrotum. You also can see on this that at first, you don't have a bladder and a rectum, you have a cloaca, and this is like around 10 to 14 weeks of development. Have you ever heard of the term ontogeny recapitulates phylogeny. Yeah, so there you go. So this is like a bird, right? A bird has a cloaca, a reptile has a cloaca, but then they separate and you form your own urogenital sinus, and this later forms into, in the female, the vagina and the bladder, but they are different from the rectum. And then specific to the bladder, you know, there's a close-up of that. It was drawn, my daughter drew that for you. So what could go wrong with that? Absolutely nothing except that. That is a cloacal extrophy right there. And so that is the case where the hindgut and the bladder, the GU system did not differentiate, and they didn't fuse, and now you have it all hanging out through the abdominal wall. And that actually can be fixed. They're not totally normal, but it can be fixed. This is an epispadias. Okay, this is actually, what is this? A male or a female? This is a female. Okay, that's not a penis up there. That's the umbilical cord. These are the labia, and this is the clitoris. The urethra is right here, and then this is all the bladder. And right here and here, you can't really see where the ureters come out. So it's basically like you took the bladder and you totally, you know, laid it out flat. That's what you're looking at, and then there's skin all around it. And so you can fix that. Okay, you basically have to wait for it to grow, so they have to be like this for a long time. And then you bring the bladder around and close it and make it into a tube again and close their belly wall over it. And no, they're not totally normal after this, and a lot of them are incontinent for life. But, you know, you can make them somewhat normal anatomy. And in the males, you can reconstruct their penis, which is usually split in half like a hot dog, to make it somewhat normal. So this is why, you know, embryology and it going correctly is fairly important. Another thing that can go wrong in the development is the ureter can not correctly fuse into the bladder. It can, in fact, fuse other places. And so this has to be a female. Why? Because there's no prostate. In a male, you're never going to get an ectopic ureter that goes down and fuses with the urethra. But in a female, that can happen. It can also fuse with the vagina. And how do you find out about that, do you suppose? Yeah, what? Sorry, what? Incontinent? Did someone say that? Yeah. So when do you find that out, you think? Not when they're 2, because they're not potty trained, you know, 3, 4, you know, you're still like, what's wrong with you? You're still wet in the bed, 5, 6. So now they're like 5, 6 years old, and then you just can't potty train the kid, and I spank them all the time, and they never get better. And then you find out, you do an ultrasound, you find out, oh, well, they've got an extra ureter. Another thing to note is these cross. So your ectopic ureter is almost always going to be your upper pole ureter, and it's always going to cross under the other ureter and fuse below it. And that's called the Weiger-Meyer principle. The latest I've ever seen this show up, 45. 45-year-old lady came into me and had a blown out upper pole of the kidney, and someone had told her that she needed to see a urologist. So I said, okay, interesting, huh? Do you have any incontinence? She's like, oh yeah, all the time. I'm like, how long? Oh, forever. Just never stop leaking urine. Okay, well, this is your problem, and we fixed it, and she doesn't leak urine anymore. So, yay for me. Another thing that can happen is the ureter. So this is duplicated ureter, but you can have any number of duplications, totally normal, or it can be just split at a high level, then they come back together. It can be split all the way down to the mid or low ureter, or you can have actually 2 holes empty into the bladder. That can be the upper pole one can become obstructed, or like you saw on the last slide, it can be, you know, somewhere else besides the bladder that it goes into. All right, so as far as things that you might commonly see that you have to know what to do about, one of the earliest problems we see is that you'll go in to get the ultrasound done, or the mom will, and this is like a magical moment. We're going to find out it's a boy or it's a girl, but instead we find out that his kidneys are all messed up. Okay, and so The ultrasonographer, unfortunately, doesn't have much to do. They just say, oh, okay, anything you know wrong with your baby's kidneys? You go, what's wrong? And so a lot of these kids will need to be referred to a pediatric urologist, and that's probably the person who should handle this discussion, because sometimes it's not a big deal, and we go, okay, just don't worry, we'll see you when your baby's born. Some of these kids, if they have a very large dilated hydronephrosis of the kidney, probably ought to be delivered at a tertiary care center. Why? Let me see it. Yeah, I didn't necessarily say it, because a lot of them can have oligohydramnios, their lungs don't develop properly, and then they need NICU care. All right, so that's the kind of the extreme version. Most of these kids are going to be okay because it's a condition that only affects one kidney. All right, so what do you do when they're born? If they have hydronephrosis prior to being born, you got to document their urine output. Obviously, if they don't have any urine within the first 24 hours, you'll want to put in a catheter and see if urine comes out then. And then probably within 24 hours, get an ultrasound of their kidneys to confirm how much hydronephrosis they really have. So bilateral is by far more worrisome than unilateral hydronephrosis, because it could mean they have both kidneys blocked, or it could mean they have their bladder blocked. All right. Things that can cause blockage of the bladder, posterior urethral valves in males are the most common. What we showed before, bladder extrophy, that can cause it. Can you see extrophy on an ultrasound? No, not on a prenatal ultrasound, because the bladder of the baby is usually decompressed anyway. It gets a little bit full in it. So you don't see the bladders. You don't know they don't have extrophy until they're born. So severe hydronephrosis is bad. And then what do? You check their kidney function. Important point to be made. You can't check their kidney function within the first 48 hours, because all their blood has been filtered through mom's blood, and so their creatinine level is the same as mom's creatinine level, and then will tend to trend down. So a maternal creatinine will be around 1. A baby's creatinine should be around 0.2 or 0.4, and it won't reach that point. So one of the important things that causes perinatal hydronephrosis, and we're going to go through more of these, is vesicoureteral reflux, which is where the urine goes from the bladder up to the kidney, and that predisposes the kids to infection of the kidneys, and so a lot of these kids need to be put on antibiotics to prevent that. But you can't use sulfa, Bactrim. You have to use cephalosporin or penicillin. Does anyone know why? You use sulfa drugs in the first couple weeks of life. Carnivorous. Okay. Yep. It messed with folate synthesis, and I'm farther removed from you guys at this point. So don't use sulfa drugs in babies. All right. So the next thing you do within a couple of days of life, you want to rule out obstruction of the bladder, so you're going to get a voiding cystourethrogram. You fill their bladder up through a catheter, and then you pull the catheter out and you wait for the baby to pee under a x-ray. And as soon as they pee, you snap some x-rays and you make sure they don't have ureteral reflux. If you've got the catheter in, you've filled them up and they pee it all out, you know their bladder's not obstructed. So you've made some very important discoveries there. If they don't have reflux, you can go ahead and stop the antibiotics. And then the final thing you get, and you don't have to get it right away, is a nuclear medicine urinogram. And that documents the function of the obstructed kidney or kidneys and how well they drain out. And in some cases where they drain very poorly, they will need surgery to correct the obstruction of their kidneys. So this is vesicoureteral reflux. Basically, this is a picture of grade 5 reflux here. And this is reflux up from the bladder into the kidney, and the kidney is all blown out. Looks like a rubber glove that's been all blown out. Grade 1 reflux is you just barely see a wisp of it in the ureter. Grade 2 is up to the pelvis, but no dilation. 3 is dilation of the pelvis, and 4 is dilation of the calyces. Grade 5 is where it looks like just a water balloon, and that's where you're seeing horrible damage that has been done to the kidney. So what do we do about that? First consequences, like I said, it allows bacteria in the kidney, so you can get a kid that has a febrile infection. Any kid that comes in with a urinary tract infection and a fever, you have to worry about if they have this condition, and it hasn't been diagnosed. So every kid that has a febrile urinary tract infection gets one of these, a VCUG, voiding cystourethrogram. The problem with vesicular reflux is not really that, though. It's the long-term significance, because they get repeated infections, scarring, and they get functional loss. Number one cause of end-stage renal disease requiring dialysis in children is this. And what we've always done, because we know that, is put all these kids on antibiotics, okay? So we say, okay, well, we're going to put you on antibiotic to make sure you don't get these infections, to make sure you don't get scarring, so that you don't have to go on dialysis and need a transplant as a kid, because that's like the saddest thing ever. So as time has gone by, we've been like, well, maybe we don't have to put all of them on antibiotics. So now we put some on antibiotics that are grade 3 and higher, and it says here 1 through 3 we start antibiotics. The grades 1 and 2 don't really need antibiotics once you confirm that's all they have, and then we wait for it to resolve. Most of these, the low grade, will resolve spontaneously and they'll be fine. The higher grade ones need intervention. I'll tell you what the intervention is in a second. The final reason you would do an intervention, surgery of some kind to fix this, is if they're on antibiotics and they have a urinary tract infection with a fever anyway. So you're not stopping them with the antibiotics, so you need to fix it. All right. So one option that we have that's pretty cool is you put them to sleep, you look into their bladder with a scope, and you stick a needle right up under the tunnel where the ureter comes into the bladder, and you put some silicone up in there, and it makes this little bleb. This is not silicone, it's hyaluronic acid. And it closes off this little tunnel so that they can no longer reflux urine out of it. And it has a success rate of about 50–60%. Okay? Not great, but it's a whole lot better than the alternative, which is make a phalansteal incision, okay, just like a C-section incision on your little baby, and split their bladder open and cut their ureter out and sew it back in a different spot with a longer tunnel. Okay, so you can see the ureter here being tunneled in through the wall of the bladder, and that stops the reflux. Okay, this is a cross trigonal. So you see there's a hole here. We pull it through and then sew it so it tunnels farther in the bladder. And that stops the reflux. But that's a major surgery to undergo for a little kid. So we would sure like to be able to do that and get away with it. If it fails, they can always have that. The high-grade kids, the grade 5s, they get this. They get a ureteral reimplantation. The fancy word for that is ureteroneocystostomy. Forget it right now. Reimplantation. Okay. Another thing that causes hydronephrosis in newborns is uretero-pelvic junction obstruction. It's the most common thing. If they only have it on one side, this is the most common thing that causes it. And it's usually because of a small segment of the ureter that doesn't develop properly, and so it doesn't squeeze, and the urine just stays in the kidney. It's not getting transported down. And a lot of these just go away by themselves. As the kid gets older, this resolves. Okay? We get a nuclear renal scan, which is what this is. And this shows that even though this left kidney is bigger, it's also lighter in color. And so if you put these through a computer analysis, it's actually about 35% function compared to the right one. And that's a reason why you would do surgery to fix this, because it's affecting the function of the kidney. Does anybody notice anything about this study that's different than every other X-ray, CT, MRI? Switched, that's right. Nuclear studies are switched. Left is left, right is right. Good catch. All right. So the first thing you try to do is, if their function is intact, this is for uretero-pelvic junction obstruction, you wait and see if it'll resolve. And why? Because most of them will, because we can't really find what's true obstruction, what's not, with the studies we have. And that, if their function is good, it's probably not going to get worse. We then follow them over time, and if they do get worse, then we do this. We do a dismembered pyeloplasty, which is where we cut out the segment that's not letting urine through, and we sew the ureter back on in a different spot. and that results in resolution of the problem. Okay, now look at this. Did we make all of this bag of water go away? We didn't, and we don't. We don't ever intend to. So the hypernephrosis does not resolve. So if you have a patient that's had this procedure, they will always have some level of hypernephrosis, and it's okay. All right, it's okay. Remember that. A lot of people get referred to urologists because they have hydro. I tried to tell them it was okay. Now you know it's okay. Posterior urethral valves. This can be really bad. Affects about 1 in 700 live births. The first thing that happens is, so what's happening is there are valves that are like little sails back in the urethra, and it catches the urine coming out of the bladder, and it can't get out of the bladder. And so they get obstruction, they get bilateral hydronephrosis, and then they get, because the pee is not going out into the womb, they get oligohydramnios. And kids with oligohydramnios do not develop lungs normally. So they have abnormal lungs, they have abnormal kidneys, and if they have both of those, chances are these kids are not going to survive. Some of these do not survive. If they do survive and their lungs are okay, then you do I have more? Yeah, no, I don't have more. You drain their bladder, you put a little catheter in, and you let their bladder decompress, and you see how well they do. And then within a few days, you ablate those valves. You just cut them in the OR. And these tiny, tiny little babies. So we have these tiny little scopes that go in their tiny little pee holes, and we just cut them. And then they don't pee fine. They don't. Generally their bladder didn't develop very well. They have trouble emptying their bladder anyway. They tend to remain incontinent longer than other children. And so this is not a great thing. Even though we can fix it early, a lot of them have permanent damage before we can get to them. So it can be fairly debilitating. Second most common cause of end-stage renal disease in children. Moving on to something that's not about bladders and kidneys, cryptorchidism. I don't think we're going to go 2 hours, guys. I'm sorry. All right. All right, so cryptorchidism means hidden testes, okay? And basically, like I showed you a little bit ago, the testicles develop up in the upper abdomen, and then they descend down into the scrotum. They tend to be down in the scrotum, by about 24 weeks of development. But at any point along the way, they can be caught up. There's no racial or geographic predisposition, which is unusual. Okay, almost every condition is like, well, it only happens in Southeast Asia. Not this. Cryptorchidism happens everywhere. It's all kids, all boys. So in order to have normal spermatogenesis, the testes have to be cooler. Okay, so about 1.5 to 2 degrees cooler in the abdomen. And simply put, cryptorchidism is when the testes are not down in the scrotum, and that can cause long-term damage. Do you even know where that's from? This might be about Mary. Okay, all right. There you go. I saw it in the movie theater, believe it or not. So, basically, I already just told you most of these. So, some of these don't descend until after birth. So, full-term infants, it's only about 3%. Okay, but preterm kiddos, it's about 30%. Is this cause for alarm? Is this cause for sending to urologists? Probably not. Okay, if you've got a preterm baby that has cryptorchid testes, especially if it's just one of them, just wait until term, because by term, a lot of them will have come down spontaneously. Okay, by a year, 75% of your term babies will have spontaneous descent, and 95% of your preterm babies will have spontaneous descent. The principal determinant is birth weight, so high birth weight good, low birth weight bad. So your big chunky babies are probably going to have descent by a year. And I honestly don't know, but I think it's probably because a lot of the fat little babies just can't find them at first. So serious. So another reason why we will diagnose this, it's actually not cryptorchidism, is between the ages of about 2 and 7, little boys develop shy testicles. And the doctor will go to look for them, and the testicles will have already gone into hiding due to the cremaster reflex. So cremaster reflex, you stroke the inner thigh, testicles go whoop, and this age of boys, it's real. Does that make sense? In this age of boys, it's a very strong reflex, and will pull them all the way up in the inguinal canal. And if you suspect that that's happening, okay, just keep the kid relaxed. You know, put your hand on the upper inguinal canal and just slowly stroke downwards. And do we have any problem?
I think they were closing. They were just putting up tables, and it was a big bang.
Okay.
Just make sure it wasn't anything else.
So, and if you slowly push down, most of them will kind of peak back down into the scrotum. In about 10% of undescended testes, it's a bilateral situation, all right? So, you have to keep in the back of your head, and any kid that walks in with both of their testicles, can't find them, okay? Especially if they have a hypospadias, which is where their urethra is below the tip of their penis, maybe it's not a boy, all right? It can be a virilized female. Yeah, that happens, all right? So congenital adrenal hyperplasia, antigen insensitivity are reasons why they will develop, well, actually antigen sensitivity, they won't develop a phallus, okay? But congenital adrenal hyperplasia, they have an excess of testosterone, and their body responds to it, makes a little scrotum, makes a little penis, but there's no testicles to descend, so they don't have them. And so this is a possible cause of cryptorchidism. So how do you find out if they're really a male or female? Anybody? Genotyping, all right, karyotyping. Okay. Genotyping is you know, so could be any number of things, including PCR and so on and so forth, by certain genes. Karyotyping, you just take all the chromosomes, you lay them out, look at them. If they got an X and a Y, it's a boy. If they've got an X and an X, it's a girl. Of course, it's 2018, gender specific, you know, it's whatever they want to be. But at that point, they probably are most likely boy, if it's XY. So, in, what were we saying? 3%? Okay, so in some cases, in other cases, where you have a unilateral undescended testis, they actually don't have one. It's not undescended, it's just not there. Okay, so how do we classify these? They can be in the abdomen, they can be all the way up above the internal ring. They can be canalicular, which is where they lie inside the inguinal ring, and oftentimes those can be felt. Extracanalicular is where they've gone through the ring, but they haven't made it all the way down to the scrotum yet. These are easy to feel, usually. And then they can be ectopic, okay? They never made it into the ring. They can go anywhere. They can be in the perineum, they can be down in the leg, okay? Weird. They can go suprapubic. They can actually go into the other side of the scrotum. So the most common place is kind of in a superficial pouch, high on the belly, kind of right to the left of the belly, or to the side of the belly button and below, is what they're talking about there. And then retractile we talked about, any kid between 2 and 7, most commonly between 5 and 6. A mom comes in and says, oh my gosh, my kid's testicles are missing. Okay? First off, weird. Second, and then the other thing is you'll ask them, well, were they there before? Like, I don't, you know, look now. But no, I seriously have never had a mom tell me, you know, yeah, they were there yesterday, but they're not there today. I mean, it's always like, I just don't think he has them. But most of the time, in that age group, it's like, okay, let me show you where they are. And then some of them, like we said, are absent. So how do you know if they have bilateral non-palpable testes? Okay, you've done your X, they're XY. Okay, they're XY. Does that mean they have the testicle? No, it does not mean they have a testicle. If they're XY and you do a test of their FSH and it's high, especially in older boys, then they don't have testicles, most likely. Okay, if their FSH is not elevated, then you give an HCG stimulation. Why HCG? HCG is an analog for luteinizing hormone, LH. Okay? So you give them HCG, and it should cause their testicles to spike their testosterone. And if it doesn't do that, then they have bilateral anorexia. All right, another thing you can do is feel them, right? Okay, well, that's how you discover they don't have any. But what you cannot do, what I encourage you never to do in a quest for the testicle, is imaging of any kind. It doesn't work. Ultrasound is the culprit, okay? Primary care doctors will send their kid to a urologist after an ultrasound was unable to find a testicle, all right? Here's what we found out. The most common cause of a testicle found on ultrasound is an enlarged lymph node, not a testicle, all right? So they go, oh, don't worry, he's got a testicle up there somewhere, but it's, you know, and then we look at it and we're like, there's no testicle there. So ultrasound, bad. In fact, if you look at the difference between the imaging accuracy is 44%, worse than the flip of a coin, worse than the flip of a coin. Slightly better is your exam, all right? A non-urologic examiner has a better chance of finding the testicle than a ultrasound, CT, or MRI. For God's sake, do not do a CT on some little kid and expose them to, you know, like Hiroshima levels of radiation in order to try to find their testicle. It's not going to help. So, you got the message. I've now helped the world become a better place. Another thing that can be done, and it usually is, if we can't feel a testicle, is we take them to the OR, put them to sleep, fill their belly up with gas, and put a camera into their abdomen looking for the testicle, because it should be hanging out. You can see, do I have a picture? No. You can see where the vessels go down into the inguinal ring, and usually also the vas deferens. So people say, okay, well, there's a vas deferens there, means it's a testicle there. Wrong. Vas deferens does not mean there's a testicle there. The vas deferens exists whether or not there's a testicle. It is embryologically distinct. But the vessels you can follow into the canal or up to a place before the canal, and if they end blindly, there's no testicle. All right. If you find the end of the vessels, then there's no testicle there. Okay. If they enter the inguinal canal, then you have to go down, make a little incision in their groin, and try to find it there. And again, you try to find the vessels. And then if you see it, but it's intra-abdominal, you can try to bring it down. Or you can do a Fowler-Stevens orchopexy, which I'll tell you about in just a second. I'll only tell you about it because it's cool. Probably not because you'll ever need it. Okay, so why do we care? Why is such a search for the missing testicle? Why don't we just say, well, he's got one, if he doesn't, he doesn't? Because the longer it stays there, the more aberrant the tissue in the testicle becomes. So they get impaired spermatogenesis. By a year and a half of age, they're already having abnormalities of sperm. And a kid that has a testicle there for, by the time they're 5 to 10, we don't know the exact age, by the time they're, you know, in their elementary school age, their testicle's done for reproduction. They will be dead for the purpose of reproduction. Still can make testosterone, but won't make any sperm. Okay, and that does affect. I mean, they have another one, but it does affect their overall fertility. So you want to save them that. You want to save them as soon as you can. Like I said, the Leydig cells, which make testosterone, may or may not be affected. Sometimes that's fine, no matter what you do. And then, in boys with cryptorchidism, the testicle cancer rate is higher. Now, we do not make that better by bringing it down, because of whatever causes cryptorchidism probably also causes testicle cancer, is the current theory. So we can't modify that by bringing it down. But what can we do? Bring it down to scrotum, what's different? No? Oh, you may not know this, you can feel it. Okay? It's right there. Okay? So you can feel it. You can put your hand down there and you can feel your own testicle. You can't do that if it's up in the abdomen. Okay? And that'll tell you if there's a tumor on it. So, I'm sorry, you're all young, you may not know this already. How do we correct it? All right, so the easiest is, and the most common, is a one-stage open orchiopexy. So the testicles in the inguinal canal, we strip off a lot of the muscles that are holding it up, and we bring it down to the testicle, we put a stitch down in the testicle, and we sew it down there, and it usually stays just fine. So for the testicle that is peeping into the inguinal ring but hasn't made it through yet, we do basically the same thing with a lot more pulling. Now some of these are not going to reach the scrotum because the blood vessels are not long enough, all right? So what do? Do we lengthen the blood vessels? No, we cut the blood vessels. What? Cut the blood vessels of the testicle? You crazy, Dr. Heinlein? I'm crazy, and we do it. Why? Because there's more than one artery going to the testicle. There are 3. And if you cut the main artery, the testicular artery, about 70% of these testicles are going to survive just fine. That's all you do in that surgery. You cut the artery, and then you say, okay, see you later, testicle. And you come back in about 6 months, and the other blood supply will have enriched. And then you can pull that thing down in the scrotum. And it's great. It's like a miracle. So, besides surgical causes, of course, everybody who's not a urologist wants there not to have to be a surgery for this. So HCG can cause the testicles to descend. If it's me or my baby, I'm not going to rely on that because it's not a very high rate, and you're only going to do that in certain cases. So one of these was a kid who had a lung problem as well and couldn't undergo a surgery very safely. And we put him on HCG, and the testicles didn't come down. But that's why you would do it if surgery is essentially unsafe or undesirable. Okay, moving on to testicular torsion. Disclaimer: this is not my scrotum. This is one that we operated on. And so, what is testicular torsion? We'll start out at the very beginning. Historical perspective is fascinating to me. It's fascinating how far we've come. So back in 1810, this guy named Hunter, there are no first names. I don't think first names were invented until like the 1900s, but Hunter described a boy or a gentleman who had scrotal pain after ice skating. That's another surprise. Who knew they had ice skates back then? And then later came back into the office and was found to have a testicular atrophy. So he started thinking, what could be causing this? Apparently never found another case. And then Lorenstein, whoever that is, described what actually was happening, which is twisting of the testicle around its blood supply. And then in the 1913s, this guy, not even try that one, said, well, if a kid comes in with acute scrotal pain, what we should do is explore them surgically. And then later on, we decided that we should do that as soon as possible, within 6 hours. All right. So, in general, acute scrotal pain, testicular torsion has to be the first thing you think of, but there are other potential causes. All right. So, you will generally see tenderness, palpation, scrotal swelling, and nausea and vomiting. And the swelling can be quite impressive, like that. Even it can be worse than that, in fact. It's really impressive stuff. So what are your other thoughts? So torsion is the number one you got to rule out. But epididymitis or orchitis is an important one, very common. Incarcerated inguinal hernia. That doesn't have anything to do with the testicle. Why do we need to worry about that? Because it could be deadly, all right? Incarcerated inguinal hernia can kill you, and you don't want to rule it. You want to rule it out. You don't want to forget about that. And then, of course, besides testicular torsion, there's torsion of the testicular or epididymal appendages, which I showed you on that picture. And while you won't lose the testicle, it's very hard to differentiate. It's very hard to diagnose. You're like, what could this be? It's not epididymitis. There's flow to the testicle. So it's a possible entity that's out there. So what happens in testicular torsion? Well, you'll generally see that they're active, all right? It's someone who's been active, or they wakened up from sleep like this. They usually have a very abrupt onset of pain, and it usually came like that. I mean, it's like they had no pain, and all of a sudden, excruciating pain in their testicle. Things we think about in people with other scrotal conditions. So bowel habits. Why did I mention bowel habits? Okay, one of the most common benign causes of testicular pain in little boys is constipation, all right? Believe it or not, constipation can make the nuts hurt very bad. And people will come in and you'll do an exam, and then the differentiating factors, you'll squeeze them, and they'll be like, no, it doesn't hurt any worse. And they're, well, maybe this is coming from somewhere else. And that's called referred pain, all right, referred pain. Referred pain goes to the testicles a lot. Does anybody know why? We've already talked about it 2 or 3 times, but not specifically that. Okay, where do the testicles develop? In the abdomen. Okay, and what is the lining of the testicle called? Do you know what that's called? Tunica vaginalis. Okay, what is the tunica vaginalis really? The peritoneum, right? And so any irritation to the peritoneum and the scrotum, the tunica vaginalis, can cause pain throughout the belly. And likewise, pain throughout the belly can cause pain in the scrotum. So kidney stones, constipation, urinary tract infections can be referred into the scrotum. So dysuria and voiding symptoms. So somebody has a bladder infection, that can be referred to the scrotum. It can also be descending infection into the scrotum from the bladder, because the vas deferens are hooked into the urethra. If they weren't, you wouldn't be fertile. And then has that happened before? And then immunocompromised. So patients who are on steroids, who have immunocompromised states like HIV or cancer, chemotherapy, are more likely to get infection in their scrotum. Okay, so when you're examining, of course, vitals. Why do I put that on there? 'Cause I probably could get sued if I didn't put vitals on there. High riding testicles. What does that mean? That means the testicle is significantly higher in the scrotum than the other testicle, and actually sometimes rotated about 90 degrees. It'll look like it's laying. So they tend to lay long axis up and down. These would be laying long axis left to right. Edema, so swelling in the scrotal wall. Swelling in the scrotal wall tends to be present in infection and not as much in torsion, but they can be swollen. Hydrocele, that's fluid within the tunica vaginalis. And so that really doesn't mean a lot, except that there's something going on there. So torsion can have a hydrocele, infection can have a hydrocele. It's called a reactive hydrocele. Generally, I will sometimes see a provider see the patient, go, oh, well, you've got a hydrocele, that's what's hurting. Hydroceles that happen spontaneously don't tend to be painful. So if there's pain in the hydrocele, don't blame the hydrocele. Absent Prima Steric reflex. So 0% of patients with a testicular torsion have a normal premasteric reflex. So another thing, you want to feel up and along their belly, along their anal canal. Is this a hernia? Hernias tend to come down through the anal canal and poke out into the scrotum. And then you can even see if you can push that back up into the belly. Okay, so you can reduce it and it goes away. Well, that was a hernia. So manual detorsion, interesting thing. You can take them if they'll tolerate it and you generally turn it out like you're opening a book. If it's on the patient's right, open it towards their right. If it's on the patient's left, open it towards their left. And that's how you can manually detorse it. Are you gonna let them go from the ER at that point and go, hey, you're good? No, you're not. You're gonna continue treating. In a sec, I'll tell you. And then consistency. A long time towards the testicle tends to get soft. They get real soft and mushy. So like I was saying, you should generally, so this is about detorsion. When you're examining, you can see if you can detors them. If you turn it about 180 degrees to the side designated, and it relieves the pain, guess what? You have a question back there?
Yeah.
Okay, go ahead.
Is it always going to twist the same way?
No, more likely the way I said than the other way.
Okay.
But sometimes it doesn't work. Manual detorsion is great. I've done it like 2 times, and it was awesome. But you still are going to take them to the OR. All right, and I'll talk about that in a sec. So what happens is they'll have almost immediate relief of pain, and then the testicle will go back down to its home in the bottom of the scrotum. So if it does not relieve the torsion, you can try turning it the other way. Okay, you can try going inward with it, but probably only 1 or 2 attempts is all you need to do just before deciding, well, this isn't going to work. We need to do something else. So cremaster reflex, to check for that, you stroke the inner thigh. And then this is kind of some insight into why this works. It just goes up the ilioinguinal nerve, down this genital branch of the genitofemoral nerve, and it's almost the same nerve distribution between your thigh and your scrotum. So they have this reflex, and it goes away when they have torsion. It goes away completely. Ultrasound. Okay, if you remember one thing about testicular torsion, it's ultrasound. Okay, torsion ultrasound, cryptorchidism, no ultrasound. Okay, you get a Doppler ultrasound to document blood flow into the testicle. If there's blood flow into the testicle, they do not have testicular torsion. And at that point, pretty much anything you do is going to be cool. If they do not have blood flow on their ultrasound, the clock is now ticking. This is the most litigious process in all of urology because a large number of people lose their testicles no matter what we do. But if you have shown that you've done everything in your power to summon the urologist and get them into the OR to fix the testicle, you're not going to be in trouble. Unfortunately, a lot of people get transferred. Okay, they say, "Oh well, don't have a urologist, or our urologist doesn't treat kids, or something like that." It's a real problem. It's a real problem in our state, believe it or not. So you should definitely, if you're talking to a urologist, you're out in manning an ER somewhere, and the urologist says, "Yeah, I don't really treat kids." You should probably involve your hospital CEO. Your hospital's at massive risk for getting sued if you transfer that patient when you had a urologist on staff, because they're going to lose their nut, period. So get the ultrasound, and if there's no flow, get your urologist in as soon as possible. Tell him to put his beer down and get in there and fix the leak. Okay? Those are your statistics. Your sensitivity is very high. Your specificity is positive. Means that you do have torsion, right? So can you have a false positive? Yes, you can, but it's pretty unlikely. This is what it looks like. So you'll notice that on the left side there is flow inside the testicle, yay. On the right side there's flow, but it's all in the skin and surrounding structures. Inside the testicle itself, no flow. Dying testicles, screaming for help. All right, so why does it happen? Why does this happen to some people, not to others? So we believe that it's due to inadequate fixation of the testicle by the gubernaculum, and so it allows the testicle to rotate freely. It's called the bell clapper deformity, and to be honest with you, I really don't know why it's called the bell clapper deformity. I've seen pictures and people have tried to explain it to me, and it's just maybe something's wrong with me. It doesn't look like I don't even know what it is, a bell clapper. Is that the thing that's on the inside of the bell? Testicle doesn't look like a bell, so I don't know, but if you hear bell clapper deformity, that's associated with testicular torsion. And because this is a predisposition, a genetic condition, we presume that the other side is affected as well. All right. So even if you save the testicle, that's a dead testicle right there. So even if you save the testicle, you need to go and fix the other one down to the scrotum. All right. Yeah. Sad. So again, irreversible ischemia happens within 4 hours. About 50% of men detours within 4 hours will have a normal semen analysis afterwards. If they're detours within 8 hours, they might retain their normal testicle size with some morphologic changes. After that, it's downhill rapidly. They're losing their testicle almost certainly. So regardless if you can torse it or not, you need to explore it. Someone needs to explore it. And you should have to do bilateral testicular fixation. That's called orchiopexy. You do bilateral orchiopexy to avoid any further torsion. Okay? You don't know if that kid that you manually detorsed is going to walk out of your ER and tores again on the sidewalk outside the building. So, because this is a, life and, not life, but a limb threatening, and the testicle, I guess, is a limb, problem, you want to make sure it's fixed before they leave the hospital. Okay? And, talking down here, you can make one big incision or two little incisions, doesn't matter. And that's really for, so there you go, there's the 2 incision method. Again, this is what a good testicle should look like. And this is, that's a bad testicle that was detorsed and is now being fixed down to the scrotum. You do put it back in. Okay, this one isn't going to make it. This one is in later stages of disrepair. All right, and what happens to their fertility? So if they have unilateral torsion, about 50% of patients will have some impairment, and about 36% of patients will be subfertile. Okay, that's based on semen analysis. All right, it doesn't necessarily mean they're going to be less likely to have a kid. So we really haven't actually done those studies. We've just done sperm studies to see what their sperm looks like afterwards. So about a third of them, after a torsion, have sperm counts less than average. And that's the long-term results. All right, moving on to infections. So what causes urinary tract infections? So first off, I will tell you that some people just get urinary tract infections, and it's mainly women. Women get infections early in life. Men get infections late in life due to their prostates. Okay, but if we're looking at things that we can fix, stones get infected frequently, so taking out stones prevents infection. Prostatitis causes further infection into the bladder. Fistula, okay, fistula from where? From the gut. Okay, so diverticulitis, people get diverticulitis and then it'll resolve, but then they get all these urinary tract infections because during their diverticulitis their colon fused to their bladder and ate a hole into it. That's no good. Foreign bodies, I've seen a coat hanger in someone's bladder, like a piece of a coat hanger, and I've also seen a swizzle stick. Yes?
With the fistula, what about patients with Crohn's?
Yeah. Big cause of fistulas is Crohn's. Radiation also. So if somebody's had radiation to their rectum for a rectal cancer, they can later get a fistula into their bladder. So back to the cool thing, it's a swizzle stick. All right? How did I find a swizzle stick? Well, there's a big stone in the guy's bladder, and as we're blasting the stone with a laser, we see that it has a nucleus on the inside. Yes?
Swizzle stick.
It's like a coffee stirrer for cocktails. Yeah, it's like a thing that's in your martini that maybe sometimes it's like a long sword. It has a little handle and your olives are impaired on it. Yeah. But this one was just the regular one. It was red and about that long. And it was in his bladder, and we were blasting it with a laser, and we started to see, we're like, there's something in the middle of this stone. And in fact, it was a swizzle stick. So we had to take that out, and when presented with it later, we were like, how'd this get in your bladder? He's like, I used to do a lot of cocaine. True story. So don't do drugs. So
he was honest. It wasn't like, I don't know.
No. People, when you catch people on the act, I guess this is sort of the act, then they usually will come clean. Except if it's in their bottom, that's another story. Then it's always, I fell. So moving on. So you guys need to break for 55 minutes. Let me see what number we're on here. We're on 55 out of 100. That's 7. Want to break? You want to go? All right, break. Go. Okay. All right. Let's have a quick break.